So we have started recording there, and then we do make the meeting minutes available also on the website. And I feel like there is one other thing I was going to say. Oh, yes, introduce yourself, please. If you could use the chat function to introduce yourself, that will save us a little bit of time as we get started. You can see the agenda for today. We want to spend a good amount of our time talking about the work group survey and report results. So there was a survey, but all the survey results fed into a final report recommendations that were attached to the email. So hopefully you've had a chance. I know you didn't have a lot of time, but we will spend some time going through that today and having some conversation, discussion, and then we'll wrap up the meeting, spending some time talking about how we want to use next week's meeting and just thinking about next steps from there. So I turn it over quickly to Tim Marshall to see if he has anything else to add.
Yeah, so good morning, everybody. Appreciate everybody joining. Looks like we're up to about 25 folks. It's always a good turnout for this group, so we appreciate that. We believe the work is mostly done. So these recommendations are completed and went out. We thought because we got them out so late or so early that we would spend some time reviewing them, but the work was done and completed. They've been distributed to the various groups that we have been talking about, and they could go forth and be utilized in a number of different fashions from here. So really today is to kind of just review what this group came up with. And then if there's some additional suggestions about promulgation, or we do have a moment to just say, did we miss anything? Or is there something we could add to as this already, as we said, went out into the appropriate parties? Also, similarly for our next and last meeting, and if the group feels like we are concluding our work with today, that's fine too. We definitely are feeling like we want to wrap up at the very least at the next week. So just to reiterate a couple of those points. So appreciate that, Jeff, and back to you.
Okay, so let's dive into it. And we, like I said, in the email that you received, I think yesterday, you had copies of both the final report recommendations as well as PowerPoint deck. So Elise, if we want to just go right into the PowerPoint, let's screen share that, and then we'll cruise through that and just give you a sense of where things landed if you haven't had a chance to look at the results. So the next page. So in that first question, or if you recall, if you've been part of these meetings, you know that we've been bucketing these recommended short-term solutions into 4 or so different categories. The first is, how do we prevent more youth who don't need to be in an emergency department from entering there to begin with? And so we had a number of recommendations and ideas that came up that we put into the survey. And when it all came out, I think it's helpful to look at the percentage, I think at least, of people who responded and ranked each one of the recommendations either in the first or second position. And so the first recommendation, which was endorsed as a top 2 by 82% of respondents, talked about expanding the use of mobile crisis to triage more youth to serve as an alternative to the EDs. Elise, if you don't mind coming off mute, can you just remind, like Christine, you're right on top of it. Elise, could you remind me what the N was? How many people responded to the survey?
We received 27 responses.
Okay, and it went out to something like 40 or 45 people, and we got 27 responses. So by survey standards, the response rate's pretty good, actually.
So Jeff,
over half. Go ahead.
Just a pause right here for a second, because there was a little bit of a conversation in the chat at the end of the last meeting. So my comment about the survey, we've been roughly between 25 and 30 folks attending routinely to this meeting. So our assumption is that generally the folks who have been most frequently attending were the ones who filled it out. But again, we could be wrong. We didn't have a way of measuring that. We started to pivot this survey and develop it, and then try to get responses from consumer families and other stakeholders. And that didn't feel right in terms of them just having not been a part of this. Again, family members had been all the way through all of the children's behavioral health plan. And as these groups spun out, one of the downsides of that was we lost family participation or robust family participation. So a separate independent one has gone out, and I believe those survey results are much more robust and are coming in and due by the end of the weekend. Elise, what was the last count of those family and consumers?
It was 93.
93. So we're going to be compiling those also. We'll be sending those out in a very similar format as we have here. What we sent out, you should notice, was really two documents. It was the priorities as the first part, the top three, if you will, of each of the 5 categories. But we felt like there is a need for people to be aware of the entire list. So the Appendix A is really the full list. And again, people may be able to reference or utilize or educate people to all of the recommendations that this work group discussed with one or the other of those. So we just wanted to be sure about that. So thank you, Jeff.
Yep. And Tim, while you're off of mute, Carl had a question about who has already received or will receive the document of work group. Well, I guess we could call not just survey results, but really work group recommendations or work group report. Can you just kind of review who has received it and who will receive it?
Yeah, so it went out to the group that we said this from the very beginning. We've articulated the group it was targeted for. So our job was to deliver recommendations to the Children's Behavioral Health Implementation Advisory Board and the 12 commissioners. So it went out to that group. Additionally, it went out to, there is a interagency commissioner work group that has been meeting weekly, similar to kind of like the hospital association's meeting. It went out to that's the five commissioners. So those 5 are also on the Children's Behavioral Health Implementation Advisory Board, but it also has members of the governor's office and OPM who also attend those meetings. So it was there. It went to the tri-chairs of the Implementation Advisory Board, and I believe that's it. Well, I think it went to the partnership was the other one. So those were the folks that, and there was a discussion or some suggestions in the chat about inclusive of legislators. I think that, these are now public documents. People can choose to do as they see fit with them, but that wasn't within our parameters or all the scope of the work that we were asked to. And again, just saying that respectfully as an executive staff member under the governor's leadership. So, and my commissioner. So just the way it was kind of designed. So back to you, Jeff.
Okay, thanks, Tim. So we talked about the first one around expanded use of mobile crisis to triage and divert more youth from the EDs. The second highest endorsed at around 48% was expediting the implementation of one or more behavioral health urgent care centers or some similar model and collect pilot data. And then the third at around 44% was to engage State Department of Education and local schools and LEAs around federal funding. One of the priorities of which was around expanding social emotional learning and student mental health needs, and to provide some technical assistance or oversight to schools in terms of how those dollars are being implemented. So, and then you can see 4th and 5th were endorsed at much lower percentages than those top 3. So let's pause right there. And if you want to use the raise hand function, that might be the best way to field questions or comments. But let's pause for a moment and just get people's thoughts and reactions to those.
See you there, 5:30. Okay.
Okay, sounds like somebody needs to go on mute. Elise, I don't know if you can mute people from our, but any comments or questions about this slide? Okay.
Can I just insert one more comment here,
Sure.
Jeff? I should have mentioned it in the last. So, we wanted to stay true to the integrity of this work group, and so that's what we did. However, there is a number of ways you can slice this information, and so I don't want to presume or assume that we all would agree that these are the quote unquote right primary top ones, because different circles, people might come up with different suggestions. So this is the result of this work group's work. I just want to be clear about that. And we assume that if you are in different categories, and broadly speaking, cross sectors, primary care, behavioral health, just different areas might come up with different suggestions. If you're in, a provider, community-based provider setting, or if you're in a hospital setting, or if you are families or consumers, you might have different responses. So again, this is just this work group's feedback. So we were trying to present them in the way in which we set out as a work group to do that. But at the same time, there may be other perspectives other than this work group, the way this proceeded. So just wanted to acknowledge that too.
All right, thank you, Tim.
Thanks for that comment, Tim. I appreciate that, there are other perspectives that are not necessarily represented here. I will say, I have been in other settings recently where, this issue is, kind of not the primary or central issue on the topic of discussion, but some of these things have in fact come up. And I will say, I heard kind of unsolicited and without a specific focus, a number of calls actually for urgent care as a strategy for addressing the ED crisis. I also heard a kind of a stronger call for increasing on-site school-based mental health services. So those kind of seem consistent with some of the things that I've been hearing in other settings.
Right. And also, while we're on this topic of just kind of providing additional context, also keep in mind that these are just the short-term recommendations. And in other work groups and in other settings, more of the emphasis has been on things that could be implemented in more of an intermediate horizon or on a long-term horizon. Equally important and also need to be part of the conversation and planning. But again, from this work group, this is what emerged, having to do with short-term recommendations. Okay, it looks like I think it may have missed a chat. Anne, do you want to come off of mute and ask that question?
Yeah, I thought we recently received some federal dollars and did make an investment to expand access mental health in the last few months. Did that not occur?
Yes, that occurred, and just literally some of the final approvals were just occurring, I believe, this past week. So I think there are so many of the ARPA proposals that are in progress or have been completed, and getting out the money into contracts. As you can imagine, with multiple state departments doing that, there are a couple points of bottleneck. All contracts have to go through internal state departments, contract division, fiscal division, and then goes out to the Attorney General, and then it goes out for execution with the provider. So a whole bunch of contracts I know internally at DCF are in that process and on the way. And what I'm hearing from a bunch of my other state partners is it's very similar. So there's a ton of stuff that is in the works. It's just how quickly can money get into a contractor, and when does hiring begin? And then as soon as hiring can begin, we're hearing about challenges of doing that. So we're all moving fast. It's just, again, there's a whole parts of this.
And the access mental health investment wasn't ARPA, right? That was different funding that came in. Correct.
Correct. I'm putting it in the context because it's still, whether it's general fund dollars, ARPA dollars, COVID dollars, there's 4 or 5 different pots. It's all still falls in that same routine of process of getting it out.
So I see Sarah, I see your hand up, and let me jump in quickly on on Sherry's comment and then yours as well, and then kick it over to you. But this issue of looking at how bed stays, length of bed stays and intended stay upon admission I mean, what the screen you're looking at right now is about preventing youth from unnecessary ED visits. The subsequent slides address issue of timely discharges from inpatient or PRTF level of care, which we understand also has an impact on ED throughput and other areas of throughput in the system. So we'll get to some of those ideas, but let me just turn it over to you, Sarah, to comment further on that.
Yeah, so actually I had another comment, but yeah, I do think that that's really important, right? Because we need to know, and I think I said this in our last meeting, we need to know more about how long beds are being occupied, by whom, and why. What are the discharge recommendations? What are folks not able to access in the community? Having collateral data around how many kids bounce back to the same or higher level of care in a 30-day period 60-day period would also be really informative about what they're not able to access in the community, right? So I don't know if there's a mechanism right now for analyzing that on an ongoing basis, whether exclusively on the Medicaid side or across payer. So, but I think that as we make these short-term investments, that's really important. My second comment is, I may have missed it because I was having trouble getting on for like the first 5 minutes of the meeting. So I don't know if Tim, if you were able to share, you know, the commissioner level meeting with DSS and DCF and DMS and the governor's office looking at these issues. Is there anything concrete that is coming out of that group that, and if you shared it already, then I'll just catch up with you offline. But if you didn't, that you can share with this group that relates to the work that we're doing here.
So great question. And to be perfectly honest, I actually don't know the answer to that because of this. I was just asked to join to that weekly group 2 weeks ago and was asked to chair it, and chaired my first meeting 2 days ago. There are a lot of conversations occurring there. So I can safely report there is a huge number of activities that group is focused on. They were very interested in this work group's recommendations, and we had some preliminary results on Tuesday afternoon before we finalized this on Tuesday night, and just gave them a peek out of just 1 or 2 items that they were interested in, but they received this full report. What I am just failing to be knowledgeable about is, of those activities that were discussed there, what of those are for public information and dissemination. I will say that my suggestion was that we need to do a better job of transparency and connectivity between all the different groups that are working out there. So I will be sure to make sure whatever information is shared there that is public, that I will, going forward, look to do that.
Thanks, Tim.
Okay. Jan, do you want to come off mute and address this? I think, and then let's move to the next slide after that. Jan?
Yes, I can come off mute. Hello. I was just commenting that our internal data shows that our volume for March, for example, of 2021 was just a tad higher for total incoming kids than March of 2019, but that the boarding increased, the amount of hours or kid boarding in the ED increased by something like 350%. And a big part of that delay were kids not being able to get to other levels of services from the inpatient unit. And some of those were delays to obtaining foster care placement with appropriate services in place, or foster care placement already in place, needing more service supports there. Some of it was residential care. Now COVID also slowed things down with quarantines and things like that, but that was a big piece of it. And I think that's starting to reemerge again. So having a better sense of those stress points is be important, I think.
So I think the balance of the last couple of comments, I know there's a lot in there to unpack, but one of the things that I think is important for us to consider going forward is making sure that we have something closer to real-time data on emergency department volume, characteristics of youth with behavioral health needs who are utilizing EDs, and then, again, more closer to real-time data on ED discharge delay reasons, inpatient discharge delay reasons. I think that that's still the availability of timely data is still a gap in the system. It seems like we're always kind of behind the game on that. So that's an area for development that I know is of interest to getting better data on throughput at multiple parts of the system so that we have a better handle on where the hangups are. Okay, so let's go ahead and flip to the next slide, if you would, Elise.
It's up there.
Okay, thank you. And this one is sort of like the second bucket that we talked about, and this is around facilitating timely discharge from the ED to community-based care. So youth that have been evaluated in the emergency department or presented to the emergency department are not in need of inpatient admission and can be discharged to the community. So as you can see here, the first highest endorsed recommendation was increasing rates for the intensive home-based services that are currently underfunded. That was endorsed as first or second position by just over half of respondents. And then secondly, increasing reimbursement rates to acute and intermediate levels of care. So intensive home-based services and number one being things like MST or multi-dimensional family therapy and those other intensive in-home services, ICAPs, et cetera. And then the second having to do with acute and intermediate levels of care, and that I think referencing typically our center-based levels of care, partial hospitalization, intensive outpatient services, and extended day treatment. And that number two recommendation was endorsed by just about half of respondents. And then thirdly was another one related to the utilization of mobile crisis, having to do with expanding utilization to help bridge young people who are in the emergency department or in inpatient beds, and helping mobile crisis serving a even stronger role as a bridging function in moving those young people out from those hospital-based levels of care back to community-based levels of care. And that was also endorsed by just about half of respondents. So I'm trying hard to keep an eye on chat here. So Gary, I think Gary, your comment might have to do more with the last slide. And Tim responded to that. Are there any questions or comments about this slide? Frank, go ahead, please.
Thanks, Tim. A comment. I'd point out, the prior slide had utilization of mobile crisis to triage. This one, the difference between 2 and 3, I mean, they're both 48% there that, in terms of the ranking there. So there's, virtually no difference, but there might be synergies here if emergency mobile crisis was expanded, synergies in terms of, triaging when they come in. And then if they do come into the ED, helping to bridge them and helping them transition out of the ED. So with the idea of, rather than recommending too many different things, there might be synergies here between this and and triaging folks earlier.
Yeah, I agree with you. I think that the kind of two sides of the same coin, really, when it comes to use of mobile crisis. So there is definitely an opportunity just to speak collectively about the role of mobile crisis and helping divert more kids from immediate touch altogether, but also helping move them more quickly from the emergency department, particularly for those mild to moderate acuity youth. Jan, do you want to, rather than reading this one off of the chat box, do you want to come off of mute and talk about your comment?
Right, yes, and I just didn't want to divert the agenda either, so putting it in the chat. I'm just making the comment that we do always have a small number of kids who seem to have placed in several foster homes with disruption to the pediatric emergency room. And my experience is that there isn't a good process in place to really go through which kids should have which service. It's either we make the decision that kids needs residential, or DCF comes in and tries to find another home. And I think sometimes there are good conversations around wrapping a kid in the community on discharge, but other times it seems that this kid has tried 14 foster homes. Are we really going to try another one? And what's the process for discussing what would be the next level of care for this kid or the appropriate placement? Sometimes method seems to be, and there's, the method seems to be sometimes, well, they'll fail enough, and then we'll do this other thing. But first, let's keep trying. And it'd be nice if we could have a discussion around where we think with partners at the table, this kid could really be successful, and why another disruption we think won't happen with yet another placement. So just to, anyway, that's a comment. I think that's a real gap there in terms of a real method to discuss those kids in the system.
Right. Yeah. Thank you. I'm reminded of a best practice in New Jersey where they have their mobile crisis team in New Jersey respond to go out proactively actually to every new foster care placement in the child welfare system to make that connection to mobile crisis for those young people, since oftentimes one of the main reasons for placement disruption in foster care is frequently mental health concerns or behavioral challenges. And so that's something to consider. How can we, mobile crisis, I think, sets up well for use across child serving systems. And so the utilization of mobile crisis, particularly in collaboration with foster care system, is certainly something worth exploring. So let's go to Tammy and then Jason after that.
Thanks, Jeff. When I was completing the survey and kind of considering these rankings, one of the things that, kind of the thought that came into my head, particularly with regard to number one, is that, kind of really the need, I believe, I do think intensive in-home models can be very, very, very effective as a really strong part of the continuum, but increasing capacity there in some cases is more than just about increasing rates. And so for me, if I had had the option, I would have said increasing intensive in-home capacity and not so much rates. Because that is a solution maybe for some models or some offerings and one way to increase capacity, but there are other limitations on capacity that affect the availability of that service.
Well, so now you've got me curious. So you're going to have to tell me more about what those other things are.
Well, so a lot of these models are kind of closed, and they are, and some of them are grant funded, and some of them are fee based, and some of them are a combination. And so the rate, if you're considering grant funding, right? And it's you can have one of these teams, there's someone who says that, right? So you can't always be I'm just going to create a new MDFT team because the kind of funding mechanism in the state and the way that happens is not conducive to just kind of creating a new intensive in-home team. So anyway, it's a little bit, it's just a broader set of things that would be needed to increase capacity.
Thank you. Good point. Jason?
I just wanted to add really quick onto what Jan had said regarding, how we wrap services around kids that go home that have been through foster care, DCF custody. It accounts for a lot of time because all these conversations, they take not hours, but usually days. So these are those patients specifically that are having challenges with their custody or their foster homes. Those end up in our best case scenario, staying in the ED for a few days. We very rarely see them get out on under a day, and they can account for very long stays. Sometimes I think our longest was a month. So those ones are very challenging to Jan's point.
Yeah. And the data, the Medicaid data at least, has always clearly identified DCF involvement as being a risk factor for a variety of ED discharge delay, inpatient discharge delay. There's always pretty strong correlations for that. So Sarah, I think you were next.
Thank you. As I'm thinking about the role or some of the proposals of mobile crisis, which I'm all about for sure, I just sort of want to put out there that outside of the immediate, that sort of the immediate assessment that we're doing, and that immediate sort of next couple of days, that a key part of the model is doing follow-up care. So if we sort of think that every kid in might be 2 or 3 or 4, however many follow-up visits, it's almost like each kid in has an exponential effect on the workload of the mobile crisis teams in general. And yet it's a key part of making sure that the service works. So there just may be something we may want to think about in terms of that. What we have seen as the use of mobile crisis has gone up through the years is that the one thing that is getting compromised, because we can't stop the incoming and we don't want to, but the part that makes the model work of the follow-up visits sometimes gets compromised. So as we're thinking about trying to solve this problem, I might think it might be worthwhile to look at those things. It did say about reimbursement rates for intensive home-based services. Sometimes I feel a need to, I ask myself, because I oversee both, is mobile crisis considered an in-home service? I know that it is, but I don't even want to get into the reimbursement rate. I'll speak that the staff are really first responders often in terms of what they're dealing with out there and the pace that they have and their whole world. And for us just to remember that it's a particularly taxing job without the structure of a office-based setting to manage the stress that they're under. So just some sort of random points that are coming to my mind.
Thank you, Sarah. And Gary, to your point, just to clarify what I said earlier, you're right that the percentage of youth that present to an ED, it's a small percentage that are DCF involved, but what the point is that I was making earlier is that they're overrepresented among those who are in discharge delay status or in inpatient delay status. So compared to the proportion, a higher proportion of them are harder basically to throughput in the system. Okay, any other comments or questions, or we will move on to the next slide. Okay, let's go ahead and do that. So the next bucket we had here had to do with facilitating timely inpatient admissions. And so we listed the recommendations in that category, and around 45% of respondents talked about identified first or second position, exploring the use of technology for real-time service and bed capacity availability. So that could be something like Behavioral Health Link or Open Bed or Unite Us. Something essentially a data system that would track youth that need placement, including information for special populations, for example, intellectually, developmentally disabled and young people with autism spectrum disorder, as well as the availability of care in inpatient and PRTF beds, but also intermediate. So, some kind of real-time data tracking system that helps us identify needs and quickly link to open beds available in the state at a couple of different levels of care. So that was number one. And then for just over a third, 37% identified a dramatic increase in reimbursement rates for inpatient and PRTF beds and an active recruitment of sites who may have unused additional bed capacity. And then third, an increase of respite bed capacity was identified by a third of our respondents. Any questions or comments on these findings? As you go down the list, as you can see, there's some overlap here. Number 4 and number 5 were endorsed by 18 and 26%. So there's some kind of chunking around that middle proportion of around a third of respondents. So there's a number of ideas here that could be helpful, but a lot more spread here in terms of what rose to the top. Oh, sorry, Frank, I missed that. Go ahead, please.
Thanks. I was going to put it in the chat, but thanks. I understand the desire for a bed tracking system like that. In my experience, and now doing this every day now for the past couple of weeks with CHA, and I think it'll just lead to frustration because it'll never be fully accurate, because it's not going to show kids who are waiting for that bed who are already in that emergency department department's ED. So it could, for instance, you could see a bed that pops up available because we just had a discharge, but you won't know that there's a kid who's already slotted for that bed who's already in our ED. And I just, I understand the desire for it, but we never have empty beds. So
I agree with Frank. This is Jan, and I agree with Frank. We are over census for the last year. There's 3 discharges. They pop up on the board, but we have 10 kids in ED. It's just going to drive people in us. Or we'll have 1 bed available, but the reason that bed's available is because 2 nursing staff got punched by a kid, and so the bed's available. Mm-hmm. And so, I'm just giving you scenarios and examples, but
Yeah.
just don't see how that's going to be helpful.
Yeah, well, let me say something quickly and then I'll pass it off to Tammy, but I think it would be important to consider number 1 and number 2 together in some way. So let's envision in the not too distant future, the possibility that we were to add inpatient beds to the system. And if that were to happen and there was a little bit more availability than we currently experience, then number 1 might be actually more useful. Hopefully I'm right in that assumption, but let me pass it off to Tammy and then to Gary.
Let me interrupt really quickly, Tammy. Apologies. But I think the point we don't want to lose here is better data collection in this context is certainly around more immediate placements and moving things more quickly forward. And so that's one. But there's also many other reasons why to collect data. So the better we do at collecting data, the all we are able to do that and to have a better idea of what the need is per kid, per system. I think all of us could be more responsive at both a system level, a local level, and at a kid level. So I think I'm hearing the points and they're well stated, but there's also other parts of it that could be very useful. Tammy.
I just wanted to make a quick point about, kind of making sure, particularly as we talk to other audiences, just thinking about not equating inpatient and PRTF. I think PRTF is a level of care, although the level of care guidelines do allow for variation on this, has primarily been seen as a step down from inpatient hospitalization. And so to that extent that it can facilitate timely inpatient admissions, it just improves throughput if people are stepping down and then opening beds into inpatient. But I think the question is looking at PRTF, whether it also has the capacity to be an alternative to inpatient admission. And I think, that has been a far second, I think, utilization to date. And it's worth thinking about what the programs need to do if they could better serve that function. But the other comment I really wanted to make about respite, which I may sound a little bit like a broken record, but I do think that that respite is a very neglected part of our children's behavioral health system. And in some ways I would put it really high on my list, but potentially under another category, which is preventing unnecessary ED visits, because there is, of course, crisis respite, but there is also planned respite, which I think can be a very valuable tool in a system for actually preventing the need to go to the ED in the first place. So I would have liked to see it under the other heading as well.
Thank you, Tammy. Let's pass it on to Gary.
Appreciate the conversation. Just a couple comments. All of us are professionals, so there's no lay people on this call. So the language we're using is our academic or professional language. But consistently, and this goes back to the Sandy Hook forward and the data that's been collected, families and lay people want to know how we make decisions about placements, where there are beds available. They want to know statistics similar to many of the legislators who are not experts in our field. They want to know why this exists. So even now, as I'm being called by legislators, they are saying, well, why is this happening? And it is, of course, a nuanced and detailed discussion, but lay people want to understand this, and lay people talk about where are their beds and are they available, and why can't my kid get here and why can't my kid get that? And it was a big part of the behavioral health plan for children that consumers chimed in saying they don't know, it's not transparent, they can't tell what one hospital is doing another. And it's absolutely the case that as others have chimed in, that at any given moment, one person could be saying, well, we potentially are holding a bed here or whatever, or this kid can't go to this site because there's 3 other kids that are like that or whatever. Families don't care about that. So I would just say in what we're doing, we also need to remember that people who are not in our field want this translated down into the language of regular people, which is how can we get things done? And certainly I feel like I've been subject to a lot of criticism as an EMTS provider about the transparency of the decision-making within the system about beds and placements. And so I get it, and I think it's nuanced, but this is something, if there's going to be resources put into this from the legislature, they're not going to just say, well, there isn't going to be a way of tracking this. They're going to want to know, in the same way as one of the reasons why many legislators, in my opinion, and families think that EMPS is credible is that there's published transparent information about EMPS. So I get it, and I don't know the right answer of which way to do it. But I think we need to keep that in mind. And then when we translate these recommendations, the language that we use in translating them, of course, it can't be nuanced with the million different cuts of why a kid can't get here or there. But if I can't believe that we're going to come out of this without saying that we need a better organized data system that non-professionals can discern in some fashion. Understanding that won't be easy, but if this is ever going to change, we have to take into consideration what families are saying too. And I appreciate Tim also going back to what you said before. There's another forum for collecting feedback from families and consumers of care, because I think that we will lose credibility if we don't have that as a juxtaposition to this data. Thank you very much.
Thanks, Gary. All excellent points, and we're very eager to see the results of the family survey. And obviously, all this came together very, very, very quickly, and we adapted the language of we adapted a survey that made it available to families, and it's a slightly different approach than what we took with this work group. But we're eager to add that perspective to the mix. And I happen to agree with you wholeheartedly around the need for transparent data, so that there's a level of knowledge, awareness, and accountability throughout the system in these key parts of our work. Any other final comments before we move to the next slide? Okay, so let's go ahead and do that. It's just 10:42, so we have about 18 or so minutes left. So our last bucket here, facilitating timely discharges from inpatient to community-based care. And around 2/3 of respondents talked about increasing reimbursement rates in community-based intermediate levels of care. Another, just about the same level, 59% increased reimbursement rates for intensive home-based services. So this one looks a lot like one of the previous slides talking about intermediate levels of care, such as PHP, IOP, EDT, and then also our intensive home-based services like MDFT, MST, ICAPS, et cetera. And then similarly, 45% on number 3 talked about endorsed utilizing mobile crisis as a bridge for discharging youth from inpatient and helping facilitate that connection to community-based care. And 1/3 of respondents endorsed the idea of developing a clinic service for bridging medication management and therapy for those young people being discharged out of inpatient hospitalization. So we'll open the floor on that one. We'll take a look at the, yeah, and we do have, that was a 4th bucket in terms of throughput flow, but we have a next slide that captured a few other ones having to do with policy and process that didn't fit neatly into one of these previous categories, but we'll go over those next. Okay, so we'll just go ahead and do that. So why don't we look at these quick, and then we'll open the floor for anybody's final thoughts and reflections on this. So on the last slide of related policy and process changes, we found there to be quite a bit more spread on this slide again, kind of like one of the previous ones where there wasn't like a clear top 2 or top 3 that emerged as, 2/3 or 3/4 of people endorsing it. But there was a lot more spread here. But just under 1/3 of our respondents talked about specialized capacity for acute intermediate to levels of care to meet the needs of children with serious intellectual and developmental disabilities. 41% reported changes to existing provider licenses to allow clinic services to be provided outside the clinic setting, including changes in reimbursement to make that happen. And then 30% of us talked about or endorsed this idea of process improvements within the ED to expedite discharge. So that's, and the examples that came up in our work group discussions had to do with reconsidering the policy for having a psychiatric evaluation for every child who presents to the ED, as well as policies that would allow for mobile crisis to be on site at an emergency department to facilitate some of the things that we identified on the first couple of slides around an expanded role for mobile crisis to both divert from ED utilization, if possible on site, as well as help move youth out of the ED to the community if they're not waiting for an inpatient bed. So that, and you can, I won't read the others, but you can see everything kind of came in that 15 to 33% or so range. So there was some varying opinions here. Jason?
I just wanted to clarify one thing on number 3, and it talked about reconsidering a policy for having a psychiatric evaluation for every child. Is that an actual policy? Just to clarify, because I'm not aware of a policy that requires that. We don't do that here. We screen them and give them the appropriate level of evaluation depending on what they're here for. But I'm not aware of a policy that requires having a psychiatric evaluation. Just looking for some clarification on that example.
So Frank, I think I can see your hand up. You probably had a similar comment. So why don't we go to you first?
Yeah, I'm not aware of a policy, but this is more governed by tort law and medical liability. We can't just say if a child comes in and into the ED and they're assessed as needing a psychiatric evaluation, we can't just say that, oh, we don't have to do that. The hospitals, have to exercise due care. We can't just say, oh, never mind, just unless we could send them to an urgent care center from the ED to get that assessment. We can't just say, don't do it.
Yeah, I think probably we missed the opportunity to vet this one more fully when it first came out. I think at the risk of being wrong here, but my reading of this is the sense that the responsibility of an ED for an assessment once somebody officially enters in there is much higher standard that not all kids who end up there might need. And so the alternatives like mobile crisis might be adequate. So I think that's what this one was maybe trying to get at, but it certainly is not saying that. So appreciate the clarification on that. So we'll be sure to if that comes up and gets any legs, we'll be sure in fact to address that. Would it be a good time to take the PowerPoint down and just break into a general conversation? So from my perspective, in a summary of these recommendations, both by just taking the pulse and the temperature of where we are in Connecticut and where we've been in those last couple of weeks and the ongoing pandemic and challenges, my pitch to this group, as we know, and I think Sarah put in the chat, there's a couple legislative forums that are brewing. And there's a lot of people who want attention or give children's mental health attention. My personal opinion about these is that our challenges in Connecticut are very, very complex. I don't think there's any one of these recommendations in and of by themselves would substantially make a difference. And I would pitch that any recommendations moving forward need to be supported and other things need to occur concurrently. And you can see as we broke through in these conversations, each one of them has some complexities to them. And many of them are connected in some kind of domino effect. If we do this, then does that happen, et cetera. So I just want to continue to pitch that we need to continue to have an eye on the entire system. We need to continue to have an eye on short-term, intermediate, and long-term. So for example, I've been heard of the point about increased rates. Some people believe that's long-term, some people believe it's intermediate, some people it's short-term. And then I've actually heard recently, well, even if the rates were increased tomorrow, there's a staffing shortage. And I'm like, that's missing the point that we need to increase rates, that period. And however long that takes, and if they don't happen, we'll be seeing it next year. And if it doesn't happen next year, we'll be seeing it the year after. So for me, I would just pitch kind of a comprehensive approach to this. And there's a danger of separating out these short-term recommendations from some of these others. So I just want to tie us back to our root and that one of our routes was to put forth for this work group, this is a subgroup of the work group, to put forth recommendations on alternatives to emergency departments. And we're in Connecticut suggesting we're calling those behavioral health urgent care centers. And in addition to that, the second level of care, the crisis stabilization, that's the original task of this group. We'll put those forward, and there's lots of others that we could continue to work on. So I'll end there and then just turn it over to anybody that wants to raise their hand or make a comment. Wow, that wasn't intended to keep people quiet. There's got to be some reactions out there for not to what I said, but in general, the overall recommendations. What are we missing? Anything glaring? Is our work done? Do you want to meet next week? I mean, our feeling is essentially what we really set out to do has been achieved. Again, it's not the whole picture. We do have one more meeting on the books. 2 weeks, we'll be picking up where we left off on the behavioral health, urgent care, and crisis stabilization levels of care. So the work group will continue, but even that work we're hoping to finalize because we need to put those forth recommendations to the leadership of Connecticut. And I see Gary and then Jason.
Jason, why don't you go first? I can wait.
Okay, thanks. I guess my only question is, knowing that this group's been called short-term solutions, what is the thought on timeline to any type of change of any of these recommendations? I know like there's a lot of them, but some are, I mean, more straightforward than others. What's kind of the more curiosity? What are the next steps and kind of timeline associated with that? Is it a weeks to month, or is it months to quarters timeline?
Yeah, that's a very difficult question to answer. I certainly, it's kind of like reading the tea leaves that we all kind of try to do here and again. But a better way I think I would answer that question is, I think many of you, and certainly on my desk, multiple inquiries a day and a week in these last few weeks from multiple directions about what should we do if there was money available, what should we spend it on, who's making the recommendations. So there's all kinds of activities within the context of the executive branch under the governor and all the commissioners. There's multiple things happening within the context of the legislative process, and there's multiple things happening within the context of trade associations. So the hospital association, the community-based alliance and association. So I personally think that the most important part is to put forth this group's best recommendations to all of the above, and then see where it's going to go. I don't know if any of us has an ability to predict, but there is a desire and motivation and a willingness to hear and to listen. And quite frankly, I worry about, that's why I made the statement about how complex the system is. I worry about there's a lot of people with good interest, but really don't fully grasp the full picture of the system. And often I'm hearing very simplistic things being proposed and funded that might, quote, fix the whole problem. And so I worry about that. So Gary was next. I then saw Jen, Ann, Sarah, and Sherry. So we have 7 minutes left. So if we could keep it brief.
Quickly, the only thing, the only thing I wonder, we really have not explored or had a discussion about, is there a way to essentially build off the enhanced care clinics, which were supposed to be sort of have components of an urgent care setting, for instance, being able to rapidly provide medication and stuff like that. But these things were never fully funded. And the concept I floated to some of you is that some of them maybe become like lighthouses, so that maybe not every ECC, but maybe there's 8 or 10 across the state that have the resources that they can quickly get kids in. So they would need new resources to have a psychiatric nurse or something like that available. Because I think standing up most of the things that we've recommended are not going to happen in the short run because of all the things that you mentioned. It's really the things that have to be built off of. But it's referenced in some of the documents, so some of the comments that you've had, but I somehow or another, I guess I think that's one thing we missed, but I don't want to take up the whole time, so I will stop there. Bye.
Thank you. Thank you, Gary. I made note of that. And yes, I think we did touch upon that in a couple of fringe conversations here, and I've heard it in other settings too. Jen?
I just wanted to add to the bridge clinic piece because I don't see it particularly as helpful stepping out of inpatient. I see it as preventing inpatient. So if somebody's waiting for a higher level of care but sitting in an ER and they could be bridged and begin treatment with this type of clinic, I think it would be avoided. So I just wanted to make that correction.
Great. Thank you very much. Anne?
I just need a clarification as to whether the input from the community and families is included in what you shared with us just now, or are we going to be getting something further?
As soon as those recommendations are compiled, I believe that closes Thursday night, Elise, is that correct, or Friday?
Yes, it's supposed to close end of day today, and they're not included in these results. Sorry.
Right.
So I would just,
Go
of
ahead.
course, I would just want to make sure that, you know, before we're moving anything forward, we have incorporated that input. We do want to avoid making recommendations that do not include the solicited input of our family and community members for consideration by others. So I would
Right.
hope that we would be making sure that happens.
Yes, we are. And the way this transpired, what we felt like was not genuine was to then send this group's recommendations to that group for their response to it, because they weren't included in the beginning. So we made the decision to develop something just for them to get their opinion, and we're having a very robust response. The genesis of this work group was all of the work that we were very inclusive of all family members all the way through. That said, probably the moment that we missed the opportunity as we broke out into these work groups, not having more family representation. So trying to recreate that at this point was not an easy thing. So we are putting forth those set of recommendations as the same way that we did these. I'll go to Sarah and then Sherry.
Oh, I'm on from you. And it may not be an appropriate sort of last comment that I'll make for this group, but it seems that the word mobile crisis, that phrase has been used quite a bit, maybe as some potential solutions in a number of areas. I wonder if it's worth at some point sort of figuring out if they're going to be part of the solution, what might that system actually need to be able to meet the needs that we have, because it's being potentially considered for a number of options, but yet it is sort of a fixed group of staff who have a lot of responsibilities. So whether it's, you know, looking at the priorities, or if it's figuring out and resolving some like easy barriers, or what it might be. So I don't know if it would be a subgroup of this, or if there's some other moment to do that, but maybe we can actually do some things to be like really successful in helping the crisis that we have right now.
Great. Thank you very much, Sarah. Sherry.
Thank you, Tim. I just wanted to say I've been doing this work since 2009, and to date, the thing I hear every time I get together with a learned group of people is that we are sorely missing the data collection. I'd just like to put out there that everyone comes to this with a view of their piece of the elephant, and they all think they can see the entire beast, but nobody really can, because we haven't captured the entire beast. It's a consistent issue. And I'd really like to stress, whatever we do, whatever direction we direct our commissioners and lawmakers to go, can we please have a separate plan train going to resolve this ongoing issue? And I love the idea of the daily call and working off data collection from that point. I think we can just expand it and really make it something meaningful and useful. That's my 2 cents.
Great. Thank you, Sherry. I just, by way of reminder, in this last minute, we do have another whole full work group. That work group on data integration is setting forth long-term, intermediate, and short-term. And you're absolutely right. No separate work group ever got forward without talking about data. So it's crosses across everything. So it continues to occur. And this group was another example of it. So appreciate that. Jeff, back to you, and if any other last-minute comments.
Nothing from me. I see Carl, Carl, maybe others as well, commenting on or thinking about whether our work here is done. I would raise the possibility, at least, that we might use our meeting next week to go over the family survey results. And if there's anything else that folks have to say about our next scheduled meeting, any thoughts on that?
Jeff, just a note that as the schedule is now, this work group would meet in 2 weeks on November 4th, and next
Thank
week
you.
was reserved for the urgent care.
Thank you for that reminder. I keep forgetting that.
Yeah, thank you. I reversed that also. So yes, our apologies. So next week, we revert back to the behavioral health work group and we need to move forward there. And then it would be 2 weeks that we would come back and wrap this group up with the family results. And Carl, I'll give you the last word if you can do it quickly.
Absolutely, yes. In addition to hearing the update on the Family Voice survey, I think it would be great to get an update on what's going on with the agency commissioners meeting group and interactions, with the administration on next steps once we're done with our work. Thanks, Tim.
Okay, Carl, I was told by that group that they're having routine interaction with the Connecticut Hospital Association. I don't know if that's a different group, but my understanding was the same group. So maybe you have more information about that. I don't.
I'm sure they're doing their work, but I think consistent with the discussion we had earlier in this meeting, there's genuine interest from among the members of this group to learn more about what's happening, on the state and federal side in terms of potential, implementation of short, intermediate, and long-term solutions to the problem. So maybe an update of that nature would be helpful.
Sure. Yeah. Okay. Yes, I misunderstood. Yes. So as I promised, I will try to get as much information that I'm able to share and move forward with that. So with that, we're over time. Appreciate everybody's joining us, and thank you. And we'll see folks at least 2 more times. Thank you all. Have a great day.
Thank you for all the great work, everyone. Appreciate your help with all this. Take care.